Hello, everyone. I'm Rif Al-Malik, Dr. Al-Malik, one of the attending psychiatrists here at the University of Louisville, Department of Psychiatry. Welcome to our grand rounds. It's very much a pleasure for me to introduce today's speaker, Dr. Ali Faruqi, who is one of our residents here. He's the one of the two chief residents currently at the Department of Psychiatry. He's a fourth year resident here and getting ready to leave in just a few more months. I'm glad to be presenting Dr. Faruqi today because I just wanted to say a couple of things. You know, I very much enjoy being at the University of Louisville, and I enjoy being at the University of Louisville because we really take education very, very seriously. And one of the things that's really nice from the attending perspective is when we learn from our residents. And I got to say that throughout Dr. Faruqi's presence in our residency, I've learned a lot from him. And so it's really very nice for me to be able to introduce him today as he's going to teach all of us. He's going to talk today about interventional psychiatry and neuromodulation. And, you know, I guess you can always take the man out of neurosurgery, but you can't take the neurosurgery out of the man. So he's going to be talking about ways of actually going into the brain, either directly or sometimes indirectly with magnetic waves or other means, and actually altering the brain in a way that is beneficial. So Dr. Faruqi, you want to take over?
Yeah, thank you. Thanks, Dr. Al-Malik, for the introduction. It's always an honor to be introduced by you, and and you've been an excellent mentor for the past 4 years. I'm going to go ahead and jump into the presentation in the interest of time as well. But first of all, thank you guys for attending, and we are going to be talking about interventional psychiatry and neuromodulation. And I put a little plug in here for what I'm doing after residency, which is I'll be joining Dr. Randy Schroed at Integrative Psychiatry, where we actually do some of the things that I'm going to be talking about today. So I do have, let's see here. I do have some disclosures. Apparently, you have to disclose whenever you have stocks in certain companies. So I do have these disclosures to talk about, but obviously I've not been paid by these companies at all. Before I get started into the meat of the presentation, I think it's important to recognize that this area, which is the area of interventional psychiatry, is quite an expanding area. So there are things here that I will not be able to discuss. Those things are, you know, VNS, DBS, ECTs, long-acting injections, REMS programs, ketamine, etc. So you know, we've had other didactics or grand rounds about a lot of these, and you know, I know Dr. Nima talked about VNS and DBS briefly. Dr. Kalil talked about the ECTs and ketamine as well, and so you know, this area is really expanding. But what we're going to be focusing on instead is looking at botulinum toxin. And so, or Botox, and the use of that in psychiatry and the research that actually supports its use in psychiatry. And I'm going to make a small transition from there to talking about TMS, and then a small primer, very, very briefly, on some of the more innovative technologies coming out in psychiatry that, you know, a lot of the audience here might not be familiar with, or maybe they are familiar with, but have not looked at the research surrounding it. I love this quote. I actually encountered a part of this poem in a great Korean film called Old Boy, but I think that this has some resonance with the rest of our presentation. So let's look at Botox, or onabotulinum toxin A, which is the generic name for the drug that is branded as Botox. There are many different types of toxins. Botox is the most well-known on the market, but there are other ones as well, like Dysport, Xeomin, and Juevo. The Botox is botulinum toxin A, and the generic name is onabotulinum toxin A. So what you will see in some of the research that I present is that it is sometimes truncated as BTX, sometimes as BONT-A, but there's a lot of other names that, or sometimes just Virum or toxin. And so there's a lot of other names that are used in the literature. The way that Botox specifically differs from the other ones is in its molecular weight. So when you inject Botox into a patient, you get a spread of the toxin for about a dime. Some of the other toxins spread more, some of the other toxins spread less. And the toxin itself is actually a trade secret. So the creation of Botox, it's not patented, it's a toxin that's available in nature actually, but it's a trade secret of how they actually make the actual serum to be the molecular weight that it is. So in 1989, it was approved for strabismus and blepharospasm. And in 2002, the toxin was approved by the FDA for glabellar-righted amelioration. So what does that actually mean? What is glabellar-righted amelioration? Well, for a primer on neuroanatomy for some folks that might have forgotten, is that this is a section of the skull, sagittal section of the skull, and you can see that the glabella is this bump right above your nose here. So the dip, you have your nose, you have the dip of your nose, which is the nasion, and the glabella is the bump right above it. But so it essentially falls between your two eyebrows. So the muscles, so the glabellar-righted are the wrinkles in that region, and it is caused by 4 muscles, and 2 of which are of interest to us. The first muscle is the first set of muscles are ones that move the brow medially, and that's the corrugator and the orbicularis oculi muscles. You can see the corrugator, I highlighted that there. It goes from your nasion essentially to the midpoint of your orbit, and the orbicularis oculi surrounding the eye itself. So that pulls the brow medially. And then you have muscles that depress the brow and pull it inferiorly, and that's the procerus and the supercilii. You can see the procerus muscle here. It is pretty much right at your nasion, and it kind of fans out up towards the glabella. And so together, these 4 sets of muscles act to give this furrowed brow appearance that you might have seen, that you probably can do right now, or have seen your patients do as well. And what that looks like and how it's described in the literature is twofold. First is the omega sign. And you can see the omega sign in these 2 pictures. Some folks in some literature, especially the foreign literature, describe the omega sign as being kind of above and including the frontalis. But the more classic definition of the omega sign is indicated by the white arrow on the right picture, which is the omega sign formed by furrowing of the brows between the eyes and between the eyebrows. The dermatological literature calls these the 11s. And it's a very common site for injection of the botulinum toxin for amelioration of the wrinkles in this area. So if you look at the package insert for Botox, then you can see that the injection points that are approved for the glabellar righted are these 5 points. So 2 in the corrugators, 1 medially and 1 distally, and then 1 in the procerus. And since patients started getting these injections, physicians started noticing that there were some additional effects of the toxin on these patients. And so this is the first paper that I could find, and including our librarians could find, on the emotional effects of getting treatment for the facial lines with botulinum toxin. This was published in 2003, so 1 year after the approval of the FDA. And this is in the dermatological literature that this was presented. And what the authors found was that about 76% of patients felt more comfortable with their body, and they reported that they had a better emotional well-being after the treatment. This paper didn't go into any additional details, it kind of just left it at that. But it caught the attention of some other folks, including some psychiatrists, like Dr. Finzi and Dr. Wasserman. And what they did the first case series, and this is in 2006, of treatment of depression with botulinum toxin A. And so this is the first time that you get in the literature the use of the toxin specifically targeting depressive symptoms. Their patient breakdown was kind of interesting, all females, obviously, but they've had depression for varying amounts of time, for varying durations, everything from 1 year to 17 years of depression. And you can see their pre-treatment and post-treatment BDI scores. And it's actually quite remarkable, the decrease of the scores over time. And this opened the floodgates, so to speak, for a lot of different folks looking at Botox for a lot of different psychiatric indications. So this paper out of England looks at folks that got treatment, all white females again, they got treatment, and this paper measured not only depression, but also irritability and anxiety. And the severity of illness for these patients was not very high, because you can see the dotted lines here represent the normal score. So the patients were just barely above normal, or barely within the morbid range of irritability, depression, and anxiety. But you can see that just wherever they were, they had a decrease in the scores of the irritability, depression, anxiety scale after treatment. This scale is a self-assessment scale. It's about 14 questions, but there was a significant decrease in the average IDAS score. So I skipped over a bunch of trials in the interest of time and a bunch of other case reports and case series, and really focused on some landmark trials or the randomized controlled trials that came out for botulinum toxin A in depression. For those of you who attended my KPMA talk, I apologize. Some of these slides are going to be repeats, but some of these slides are actually going to be new. So, our goal, I think this guy needs a lot more than Botox to help him. He's quite cachectic here. I don't think that Botox would do him any favors, really. But many of you might wonder now that, I mentioned randomized controlled trials. So how is it that you randomize and control for the fact that folks are getting a cosmetic procedure done? And this is how they did it. So this is a excerpt from a study that I'm going to present a little bit later on. And what individuals did is they made the patients wear these surgical caps that covered their brow, so hit right above their eye. Now, some of you might wonder that, well, shouldn't there technically be an unblinding when patients realize that their eyebrows are not fully paralyzed? And you are absolutely correct. There is some level of unblinding that does occur just as a result of just as a nature of what the treatment is. Well, let's look at Dr. Walmer's study. So, just from a glance, you can tell that the verum and the placebo, that there is a difference. And from the number of asterisks that you see, you can probably tell that the differences is statistically significant. The primary endpoint was at 6 weeks for this study, and that's actually the case for a lot of the studies that we present today. The primary endpoint is at 6 weeks, and they chose the Hamilton Depression Score 17-point scale for their primary endpoint. And they did notice a statistically significant difference in the depression scores after treatment at 6 weeks. For those of you wondering too what CSS-GFL is, that is the clinical severity scale for the glabellar frown line. So that's how well the injections improved their wrinkles. And you can see that also pretty much went into effect 2 weeks after treatment, and maintained. And around 12 weeks, you get a little bit of a return of movement in the wrinkles in the eyebrow region. But for the Beck Depression Inventory, the Hamilton Depression Scale, and the CGIs, we see that there is improvement in these patients. This is another trial. This is a 12-week trial and published in the American Society for Dermatological Surgery. And what this study looked at is they took non-depressed patients and depressed patients, injected both of them with the verum, and looked at both of their depression inventory scales. And they saw that there was a decrease in the depression scores for the patients that received the actual toxin itself. Dr. Finzi here published another study with Dr. Rosenthal. This is a N of 85 randomized controlled trial, and it lasted for a total of 6 weeks. Again, a statistically significant decrease in the MADRS score. So you've got HAM-D, you've got BDI, you've got MADRS. So folks have looked at a lot of the different scales for depression that's used in the literature, and there's been a statistically significant difference between the Botox group and the placebo group. And so around this time, Dr. Finzi was awarded the patent on treating depression with botulinum toxin. The main study that really came out that solidified the company's decision to move forward with phase 2 and phase 3 trials was this one in 2014, published in the Journal of Clinical Psychiatry. It's a 24-week crossover study, so folks received either placebo or Botox, and at 24 weeks they switched them. And so you can see that the response for the patients for the Hamilton and the BDI in the Botox group is pretty significant, 73% response. 73% partial response, but a total response of 55% and a remission rate of 18 to 27%. Even folks that received Botox second, so they already had the initial injection and then the second injection, you get a pretty robust partial response to Botox. And then the bar graphs are even more impressive. So you have the Hamilton depression score, the 21-point score, the 17-point score, you have the BDI, and then you also have the PHQ-9. And we can see that at the end of 12 weeks, both groups that received Botox first or Botox after the crossover showed a decrease, which was profound at 6 weeks, but then it persisted at week 12. What's interesting is that you notice that there's a dip in the placebo group as well at week 3, but then for the Hamilton and a little bit for the PHQ-9, it kind of normalizes back to baseline. And the thought is that that's because, initially when you get the injection, you are expanding the muscle because you are injecting, saline into a very small muscle. And so patients might have some stiffness of the eyebrow. And then over time, as that saline kind of dissolves out and they notice that they still have full movement of the brows, that the patients recognize that they were in fact in the placebo group. But the interesting thing about the study is that it did look at a 24-week time period. So it followed the patient for about 24 weeks. And essentially at that point in time, the severity of their glabellar frown lines returned back to baseline. However, their BDI, Hamilton, and PHQ-9 stayed depressed and stayed low for the duration of the treatment. And so this is some interesting data. Interesting enough that the company, which at this point in time was Allergan, decided to go into a phase 2 study for Botox. What's interesting about the study is that they recruited 225 patients, and they were all females. And the important thing about it is that these patients were treated with just botulinum toxin. So the previous studies, there were real world type settings where their antidepressant medications or other medications might not have been changed. But in this case, the patient could have been treated in the past with an antidepressant medication, but they had to not be taking the antidepressant medications currently or any therapies targeting depressive symptoms. So this is looking at the effect of the toxin alone on depression. And the primary efficacy was addressed at 6 weeks, which is, we can see that as a trend throughout the studies, but it was addressed by MADRS at 6 weeks. And what they found was actually kind of interesting. The difference between the placebo group and the toxin with patients getting 30 units was statistically significant at week 3 and week 9, but it was not at week 6. What's interesting about this also is that the folks used what's the MMRM, or the mixed model repeated measures. And essentially what mixed model repeated measures is that it takes it for any data point that's missing, the MMRM takes the average of the group or the cohort for that time frame to fill in that missing data point. And so it's some of the values that were used to calculate the MADRS for this specific statistical measure was actually not observed, but it was calculated. Some of the missing data points were calculated. But if you look at the observed MADRS, so if you exclude the patients that dropped out, that were not, or that you had the missing data points, and you took those data points away, and you looked at just what you observed and what you saw, then you actually did reach statistical significance at week 6. But unfortunately, this was not the primary outcome. So this was labeled as a failed study. So the other, if you look at some of the other measures for depression, your CGI and your HAM-D, then you see that there is a separation from placebo, but the HAM-D didn't reach statistical significance until about 15 weeks. The CGI did at week 3, week 6, week 12, week 15, and again in week 21. But there is a separation from placebo, which is visualized because, and that's important because the 50-unit group had no separation from placebo whatsoever. So this presents kind of an interesting data because it shows that there is a therapeutic window to using botulinum toxin, that complete paralysis might not actually be beneficial, that you might just need some attenuation of the muscle movements, and that folks that get 50 units did not respond favorably, but folks that got 30 units did respond favorably. So at this point in time, Allergan decided, that they were actually going to do a phase 3 study, but unfortunately, the phase 3 study was not completed for 3 reasons, and I'm going to mention those right now. We actually tried to bring the phase 3 to University of Louisville, but we were stopped by COVID, which happened, and so obviously, in-person appointments, injections, and procedures was not done. The second thing that happened was that Allergan got bought out by a separate company, and that company then went into a different direction. They did not want to focus on the toxin. And the third, those are the 2 main reasons for that. The third reason is, of course, that there was a patent on the treatment itself owned by Dr. Finzi. So you have, my understanding is, though, that the company is looking into doing phase 3 studies for Botox with depression. However, this did not stop individuals from looking and doing meta-analyses and combining the studies and taking a look at what the literature in general shows us about how efficacious is botulinum toxin. So this is a systematic review and meta-analysis, and it was done using the PRISMA methodology, which for folks who have read a lot of meta-analysis know that this is the gold standard in systematic reviews. And they came down to 5 randomized controlled trials, 4 of them double-blinded and 1 with the crossover design. And all of these we've essentially discussed so far in our presentation, except for 1, which they included at times, but they did not include at other times because it didn't meet their full rigorous selection process that they had. So we talked about the Walmer study, the Finzi study. We talked about the Majid study, the first cohort and the second cohort, the Zamanian study that's mentioned there in 2017. That's an Iranian study, and that was excluded from some of their statistics. And then the Brin study with the 30 units and the 50 units, those are actually, that's the phase 2 trial that was published. And so you can see here that they calculated the effect size of Botox at 1 and or 1.09, and they found favorable results. So most of the studies that actually did show that Botox was effective compared to placebo and was reliably effective compared to placebo. What's interesting is that they also looked and they saw that polypharmacy and increased number of antidepressants made Botox less effective, or botulinum toxin less effective. And in addition, they were able to calculate the number needed to treat with the effect size that they found, and the number needed to treat is about 3 or 4. Now, that's kind of interesting because for those of you who are familiar with the STAR-D trial and some of the other antidepressant studies, know that for SSRIs, the number needed to treat was, I think, like between 7 and 9. And the effect size for in the STAR-D trial for treatment-resistant depression was actually 0.4. And so some comparable data here looking at depression with the botulinum toxin. And that was also picked up on by this group in China, who injected patients with about 100 units total of botulinum toxin. What's interesting here, and the reason that this study has a different result than the phase 2 trial that looked at 50 units alone, is that the units that were given in the muscles that are the treatment muscles for depression were only about 30. And that includes the 3 that you notice down here. So that's 1 in the procerus, and then 2 in the corrugators bilaterally. And then the 3 injections right above that, they were noticed to be given in the procerus and then also in the corrugators medially. So the X's don't really match up anatomically to where you would expect the injections to actually be given. The 4 X's at the top there were actually given in the frontalis muscles. They were not given in the glabellar region. And then obviously you have the injections for the lateral canthal lines. And what's interesting about this particular study is that they actually compared the toxin group to an active control group with treatment with sertraline. And you can see that the groups are pretty evenly matched, and that the improvement of botulinum toxin A with sertraline is pretty identical. In some of these, in the HAM-D and the HAM-A, which is the anxiety portion of the Hamilton score, you can see that actually the toxin outperformed sertraline. But overall, you can see that the lines are almost superimposed. What's interesting to note, though, is that the toxin ended up working quicker than sertraline did with the HAM-D. So you can see at 2 weeks, you have a statistically significant difference from week 0, which is baseline, whereas for the sertraline group, you don't have as much of a change at 2 weeks. But at the change at 4 weeks is kind of equivalent. The kicker to all this is that the side effect profile for Botox is quite favorable. There are no systemic side effects, so you don't get the dizziness, the gastrointestinal system symptoms, and things like that that the folks complained about in the sertraline group. You get some brow muscle stiffness and some asymmetry. And so the asymmetry might be profound in some patients; they might not like it, but to be quite honest, the asymmetry can be fixed with Botox as well. So it's kind of a give or take of how limiting these side effects were for the patients. So this was a very interesting study looking at the active control group, but that's not to say that other folks have not looked at different psychiatric disease processes and their treatment using Botox. This is a case series. This is actually the only case series that I found for social anxiety disorder or any kind of anxiety. And this was published a little bit ago as a letter to the editor. But it did show in the LSAS, which is the Leibowitz Social Anxiety Score, that there was an improvement after injection of Botox in social anxiety. But perhaps a more compelling reason to look at anxiety with Botox is the post-marketing surveillance data for botulinum toxin for all different indications. So what these authors essentially did was they looked at the FDA's adverse event reporting system. So they looked at the adverse events reported to the manufacturer, who then reported it to the FDA. And they looked and saw between control groups in the studies and the treatment groups with the toxin, what the anxiety-related symptoms were in those 2 groups, and whether there was a difference or not. And so they looked at over 15 million adverse events that were reported, and they were able to kind of separate them out into injections in different areas: facial muscles, facial and head muscles, torticollis, limb muscles, neck muscles, eyelid muscles, etc. And what they found was that there was a protective effect, at least from the adverse event reporting. The Botox or the toxin group did have a protective effect and not an adverse effect, except for the blepharospasm and eyelid muscles, which is kind of I think kind of understandable. But also so it had a protective effect overall. And you can see that these the confidence intervals don't actually cross 1 here. So it shows that these effects might be real. Now, obviously, this study is not looking at anxiety proper. It's looking at anxiety as a side effect of other other treatments, cosmetic use, migraines, etc. But it did show that that the patients in the treatment groups in these studies had a less anxiety compared to the control groups. And that's been our experience as well, and the patients that we've done Botox on for depression and for mood symptoms, that they did report a change in their GADs as well. So at this point in time, it's the data is quite compelling that this actually works. And this works in a little bit more than just, that you look good and so you feel good. There's probably something else going on as well. There's probably some effect in the brain proper. And so, I put this picture up there because, man, look at the strong corrugator muscles for this patient. They're really pulling his brows medially. I think this patient, Rembrandt's old man here, can benefit from the toxin. But I digress. So, is what's going on just a cosmetic effect, and we're seeing the byproduct of it, or is there something more going on neurochemically or neurobiologically? And so first, I want to show you guys this picture from one of the things that from one of the papers that we're going to talk about here in a little bit. And this shows you that compared to the control, the toxin group does have essentially very limited movement of the brows in both anger and sadness. And this is using validated methods of eliciting these responses in patients. So the authors of some of the randomized controlled trials, they pooled their patients together and they wanted to assess three independent ideas. The first is that whether baseline wrinkles or baseline frown lines and severity of frown lines is indicative of having a better antidepressant response to the toxin. And that's by model number one. And what they found by the p-value is that it was not predictive. So even if you don't have that many wrinkles around your glabella, you may still get an antidepressant response to the toxin. The second model that they used, and this is with a bunch of pooled patients from all the different randomized controlled trials, is whether the presence or absence of the frown lines whether it can be used to predict or as a measure of baseline depression severity. And what they found was that it did not. So you might have wrinkles and not be depressed. You may be depressed and not have wrinkles. So your treatment wasn't limited to just patients that had the wrinkles. And the final model showed that there was no association between the frown scores, improvement of the frown scores, and improvement of depression. So even if your wrinkles didn't get better, it's possible that your depression symptoms did improve in some of these studies. And so it's possible that you can use that as an independent factor. So what this essentially tells us is that if you're going to inject Botox, that you cannot just go based on the cosmetic appearance, that there should be some other measures for depression. Now, this is really interesting because it kind of goes against this whole idea of Botox's or botulinum toxins effect being secondary to just cosmesis. So this shows that there's probably something else going on. And what is that something going on? And so we can't talk about, why does this work? So I'm going to present a couple pieces of data here about why this works. And the first thing that I want to do is actually bring up some interesting study in animals. So this group in China essentially injected some toxin in the glabella of mice. Now, mice, the mouse model for depression is also validated and tested. But mice are also not looking in mirrors and saying that, hey, I look pretty good today. I got Botox. I'm not frowning as much. They don't have those type of behaviors that I know of. And so what happened in these mice, they were injected, the Botox was injected, and at varying time points, the mice were dissected and various assays were run to look at serotonin levels and expression of different of different genes. So first and foremost, if you take naive mice, so these are mice that have not been stressed, and after the injection of the toxin, you look at their hypothalamus, they do have an increased level of serotonin. So suggesting that there is something going on there. In addition, if you look at the mice that were treated with the toxin and then subjected to the forced swim test and the tail suspension test, then you can see that there is a change in time of immobility for the forced swim test and the tail suppression, forced swim test and the tail suspension test as well. And you can see that compared to the control groups, which is in black, the toxin group did show a reduction in time, suggesting some level of antidepressant effect in the animal model. In addition, we looked at the study group looked at serotonin levels in the prefrontal cortex, in the hypothalamus, and the hippocampus of stressed mice. So they stressed the mice first, then they injected the toxin, and then they did the dissections, and they saw that there's almost like a return back to control to non-stressed mice after the injection of the toxin. And finally, they looked at BDNF and also NR1. NR1 is a subunit of the NMDA receptor, and they looked at the expression of BDNF, SNAP, and NR1 in these mice, and they saw that there was an increase in this expression. The SNAP25 was measured in the hippocampus, and it was not different from control, so it suggests that that maybe the hippocampus doesn't get as much of the toxin in the stressed mice as we think that it does. But the other, the NMDA subunit, NMDA receptor subunits had increased expression, and that again almost returned to baseline in the stressed mice. So this is pretty compelling evidence. So it shows that there is some change, some neuromodulation occurs with injection of the toxin in the animal model. But what happens in the human model? And so this is a functional MRI study looking at activation or suppression in the amygdala and the brainstem. And what they found in this study is that there was a reduction of left amygdala activation in subjects treated with a single injection of the toxin in their glabellar region. And then they also noted that there was a decrease in the activation of the left brainstem and the left amygdala. And so there was an uncoupling. So after the Botox injection, you saw a decrease in the amygdala and a decrease in the brainstem. And so this is where, because of the study, the theory came out that what ends up happening is you have paralysis of your facial muscles, which changes the afferent sensory fibers to the trigeminal nerve and leads to changes in the brainstem that then have further downstream effects in your amygdala, and maybe even in other regions of the brain. And so this becomes kind of important for psychiatric conditions that we know have hyperactivity in the amygdala, such as anxiety, heightened fear responses, and also PTSD. And this final study is that I'm going to show about the toxin is kind of interesting. So in this study, what they did is no toxin was involved, but folks essentially put an EMG probe into the corrugators, and they stimulated the corrugators, and they looked at the changes in cerebral blood flow. And what they found was that there was a correlation between activity of the amygdala, of the ventromedial prefrontal cortex, and of the occipital cortex. So essentially what we found was that if you stimulate the corrugator muscles, then you get activation of the amygdala. What they also found was that if you stimulate the corrugator muscles, then the stimulation is inversely correlated with activities in the ventromedial prefrontal cortex. And it is positively correlated with visual cortex activity. And so this is actually pretty interesting data, because it shows that the impacts of movements of the muscles in your brow is linked in a way that's kind of a frowning movement, is linked to prefrontal cortex activity. Now, some of you might remember prefrontal cortex and why that's important in psychiatry, because it turns out that we have looked at prefrontal cortex for various other neuromodulation strategies. And so if you see here, compared to the normal control, your prefrontal cortex in unipolar depression and bipolar depression has reduced activity. And in patients that are treated with depression, it shows this little paper shows that they have increased activity in their dorsolateral prefrontal cortex. And the most effective way to stimulate the dorsolateral prefrontal cortex is through transcranial magnetic stimulation. And so you can see that the bridge that I'm trying to make here is that, the toxin shows that it has some effect on your ventromedial prefrontal cortex. And so, maybe coupling that with transcranial, with TMS, which acts on the dorsolateral prefrontal cortex and then reaches deeper structures in that direction, might have a synergistic effect, because the mechanism, at least what's proposed, is they work kind of in opposite ways. TMS, you stimulate the prefrontal cortex, you get deeper effects. With the toxin, you get some effects in your brainstem, and then that actually projects to your ventromedial prefrontal cortex. So I know that that we don't get as much exposure to TMS, so I wanted to touch on a couple things leading up to what's happening most recently within the TMS community, which some of you guys might know about in terms of the SAINTS protocol. So first of all, the pivotal trial for TMS came around 2007-ish, so the O'Riordan trial, and this looked at repetitive transcranial magnetic stimulation in the dorsolateral prefrontal cortex. Now, this protocol that they used, the active and the sham group of about 150 patients each, the protocol that they used is the protocol that ended up becoming approved with the FDA. And that's the protocol is highlighted here, 5 times per week, 10 pulses per second, 120% more threshold, essentially 3,000 pulses per session. And there is a nice, in the Montgomery, in the MADRS, there was a nice decrease in the patient's depression during the treatment and then thereafter, which suggested, and also a decrease in their CGI outcomes, with a response rate of about 50% and a remission rate of about 37 to 28% of patients. And so this essentially led to that protocol, the protocol to be approved, and multiple companies came out, and then you got TMS with the Neuronetics machine, with the MagStim machines and other machines. But the protocol that was FDA approved for a long period of time was the protocol of stimulating the left dorsolateral prefrontal cortex using repetitive TMS at 10 hertz frequencies for a total of 3,000 pulses per session. Research then went into other modalities of treatment, because as you can imagine, if you were to do that over a period of time, you essentially are looking at about 30 minutes or so per treatment. There were some protocols that shortened the amount of time between the individual trains to shorten the time, but the patient still had to come in to the office about 5 days a week for about 30 to 40 minutes total time. So next came this whole idea of theta burst. And so this is the 3D trial, and this trial looked at what theta burst is. So I have the protocols listed here. So the FDA approved protocol, like we mentioned, is here. Total duration time of treatment is around 37 minutes. However, theta burst stimulation requires about 3 minutes and 9 seconds per session. So it's a significant reduction in time with the machine. So what is theta burst? So theta burst is thought to be how the neurons, how the natural oscillations of the neurons are in the native brain, and it's supposed to mimic that normal brain physiology. It is a burst, and so this kind of shows you how that looks like. It's a triplet burst at 20 milliseconds apart and grouped at 10 total in a 2-second time frame, and and then they have a rest period after that. And so if you compare the protocols here, then you can see that you're using intermittent theta burst, which is shown by ITBS in this slide here, that you get about 600 pulses per session instead of the high frequency repetitive TMS getting around 3,000 treatments per session. And it sounds like someone's blowing a raspberry almost. So it's like, if you blow a raspberry on a baby, it's like that. That's pretty much what theta burst sounds like. And intermittent theta burst was found to have a more stimulatory effect, similar to high frequency repetitive TMS. And continuous theta burst and low frequency TMS are thought to have a inhibitory effect on the brain. So this study separated the patients into your TMS as usual group and then the theta burst group, and it found that the theta burst group was not inferior in any way to the normal TMS treatment protocols that exist. And so this led to some more research being done on theta burst. What's important to note here is that the natural progression of research is going to be, well, if you can cut treatment down to 3 minutes, then why just do one a day? Why can't we do multiple treatments a day? Why can't we do more pulses a day? And that's what the folks at Stanford thought to do. And so you can see this protocol is called the SAINTS protocol. Very, very highly publicized. Some of you may have heard about it on the news. Some of you may have heard about it at the various conferences. For those of you who are part of the Clinical TMS Society, there was a lot of conversation surrounding this in some of the message boards, and there was also a lot of emails that were sent out by the TMS Society because the results of this study were quite remarkable. There are a couple different papers that came out about the SAINTS protocol. There was a paper highlighting the protocol itself and on an open trial, then there was a double-blinded randomized controlled trial. I'm going to mix some of the slides up because some papers highlighted aspects of the one aspect of the protocol, while the next paper highlighted another aspect of the protocol. But in the interest of the presentation, just know that I'm putting information together from 2 different papers that were published, one in 2022, one in 2021. So this is fairly recent. This is in February of this year. The main differences between the SAINTS protocol and the intermittent theta burst protocol is, well, there are a few main differences. The first is how they localize the position of the coil. So as you may know, for transcranial magnetic stimulation, the neuromodulation really occurs because we position the coil over the dorsolateral prefrontal cortex. And there are a couple different ways that we can measure where the dorsolateral prefrontal cortex is. The 2 ways that are most commonly used is what's called the 5.5 centimeter method or the F3 method. The F3 method corresponds to the F3 location of your EEG probes. And there are calculations that can be done using the patient's dimensions of their head circumference and their tragus to tragus distance to calculate where the F3 is. What the SAINTS protocol did was it actually used functional MRI to really find where the dorsolateral prefrontal cortex was. And so you can see that that individualized placement of the coil to the patient. And so to do this, you really have to have neuronavigation equipment and access to a functional MRI. The blue dot in this diagram represents F3 as measured by the calculations, and all the other dots here represent the treatment locations for the patients that were in the trial. So you can see that barely any dot overlaps. And so this is really personalized and individualized treatments. The other difference is obviously that the number of pulses. There are 90,000 pulses total, 18,000 pulses per day for these patients. And these were given multiple times a day for a total of 1 week. So instead of the treatment paradigm taking about a month to complete, folks in this protocol completed their treatment in about 1 week. And what did they find? Well, the results were quite astounding. First of all, the mean reduction in the treatment groups at treatment week, and then week 1, 2, 3, and 4 was 62%, 70.9%, and 62% again, 57.8%, and then 52.5% at week 4 after treatment. And that's a mean reduction in the MADRS overall. And over the 4-week period, you get about an 87.5% response rate and about a 78% remission rate in the treatment group. The trial was actually stopped early because the results were surprisingly positive. And this gave the Stanford folks a lot of press and and a lot of media attention as well, to the point that the Clinical TMS Society actually had to come out with a statement about the SAINTS protocol. I'll leave this up here for you guys to read. I'm not going to read it for you. But essentially what this statement talked about was that the difference between the FDA cleared theta burst, intermittent theta burst protocol, which is what I showed you in the 3D trial, and how that is different from the SAINTS protocol. And the fact that folks cannot really perform the SAINTS protocol unless they have access to the fMRI. And that's the main thing, is the localization. And it has to be local. The location of treatment has to be localized and individualized to the patient in order to really say that you did this protocol itself. So I'm going to take a quick break here and kind of summarize where I've taken you so far in my presentation, because it seems like I kind of talked about two completely separate things. One being the botulinum toxin, and the other being transcranial magnetic stimulation. But they are linked, and they're linked in the fact that they both have been shown to cause changes in the brain, specifically in the prefrontal cortex. The toxin acts kind of, the actions of the prefrontal cortex by the toxin are distal. So you have paralysis of the muscles that leads to changes in the brainstem activity that then lead to downstream changes in your ventromedial prefrontal cortex. And the changes in the prefrontal cortex with TMS are more direct, and that is that you actually directly stimulate the prefrontal cortex. Both of these modalities have to do with neuromodulation, because the final impact on the mood of our patients and the final impact, the psychiatric impact on the patients, is thought to be due to actions on the prefrontal cortex. So both of these techniques fall within the realm of neuromodulation, and they present some really exciting, a really exciting roadmap of where psychiatry can go in the future, and where things might be headed for us. But like I mentioned before, that psychiatric interventions or interventional psychiatry is not just limited to this experimental botulinum toxin or to transcranial magnetic stimulation alone. There are other things other than even VNS, DBS, and ECTs. And I want to touch on a couple of those briefly, just to kind of whet your appetite about what's possible in psychiatry and what's going on in psychiatry. First is another form of ECT called magnetic seizure therapy. And so this is kind of an interesting cross between TMS and ECT, where folks use powerful magnets to stimulate a seizure response in patients. And so if you look at the comparison between patients that received ECT versus magnetic seizure therapy, then you see that the response rate, at least at day 9, which is a very short study, but at least at day 9, the response rate is kind of similar. But what the difference is in the seizure time, where ECT has a much better seizure time than magnetic seizure therapy, and also in the recovery times, where magnetic seizure therapy has a lot faster recovery of breathing, consciousness, and orientation compared to the ECT as usual group. So, I don't know if this is ever going to take off or not, but I thought it was really interesting because it kind of gives you an idea, because I didn't know that this existed until I found this article, and it's kind of interesting, and it shows movement in neuromodulation towards modernization of psychiatry, for lack of a better word. In addition, the study for trigeminal nerve stimulation for ADHD has led to the FDA approval of the first trigeminal nerve stimulator for adolescent ADHD, which is called the Monarch device. And so And so you can see that compared to the sham group, the active group did have an improvement in their ADHD rating scale over a 4-week period. And this device is approved. It essentially goes over parts of your forehead and your ear, and it stimulates your trigeminal nerve, leading to improvement of your ADHD outcomes. So there's a lot going on in psychiatry, and there's a lot going on in interventional psychiatry. And I think that the interest in these modalities and neuromodulation in general is increasing over along residency groups. You know, when we were at the Chief Residence Conference in New York, there were a lot of people there that were interested and wanted to do neuromodulation based practices in the future. Education for interventional psychiatry has not always been up to date, so to speak. You know, for example, even here at the university, you know, we don't get a very hands-on experience with some of the interventional techniques other than ECT. TMS is offered, obviously, but it's offered as an elective, so it's not a requirement of the course. And so so I wanted to kind of take this opportunity to talk about, you know, the importance of of exploring these options, of looking at the research and really trying to learn what's out there in psychiatry, because interventional psychiatry is a fascinating field. And I really think this is kind of the direction that I've found my interests and my passions leaning towards. And this paper published by our very own Vice Chair of Education, along with Dr. Lippman and Dr. Al-Malik, talking about neuromodulation treatments and interventional psychiatric treatments and how they could be incorporated in a residency group. And so we are at U of L very much ahead of the curve still in terms compared to other residency programs. And so the training that we get here is pretty robust, especially in the ECT section as well. The reason I put this paper up and this particular paragraph in general is because some of the neuromodulation treatments that are mentioned in this paper, some of them are kind of old news now. And so there's newer treatments that are coming out very rapidly. So this field is evolving very rapidly. And I think it's worth keeping an eye on it. And so I kind of want to end the presentation here with questions, but before I do, I just want to take a second to once again, thank all you guys for listening, and also, I'm about 2 months away from graduation and starting work properly, and I have to say that I really did find a second home in psychiatry. And Robert Caudell, he took a chance on me because I was, out of residency and kind of working in the administrative sector for some time, and took a chance on a wayward soul like me and offered me a home. And I really did found this to be a very natural home for me. And Dr. Al-Malik, he's been a friend and a mentor, and I want to thank him as well for for all that he's taught me and will hopefully continue to teach me as time goes on. And of course, Dr. Randy Schroet, who I will be joining in practice once I finish, for giving me the opportunity to practice psychiatry in a way that I find exciting, that I'm passionate about, and we hope to build a great practice together and to really help our patients in that way. Christy's been an excellent work mom, and which I'm sure you guys all know. And to my fellow residents, thank you for the camaraderie and the friendship over the past few years. And hopefully it won't end once residency ends for me. So thank you guys. Got about 30 minutes to spare. I thought this presentation would actually take a lot longer, so I'm kind of glad that I blasted through some of these slides.
So Dr. Faruqi, thank you very much for doing this presentation. It's really, I think, fascinating. And it's really, I just want to mention this. I think this is really high quality in the sense that you go all the way from essentially the physiology mechanisms all the way to the clinical stuff. And yeah, you know, it is important to know that in all of the decades of research about something that truly marks what part of the physiology of depression is, the reduction in activity of the left prefrontal cortex is one of the most reproducible findings. And I really appreciate your presentation that what we have here is a focal, localized, directed treatment towards an abnormal physiologic marker that doesn't impact the rest of the body, which is, you know, one of the things that we have with medications is they're going everywhere in our body. They're impacting our gut, our reproductive organs, our, you know, our blood pressure, our vascular system. And none of those things are of any importance to the treatment of depression. Whereas here, you've outlined treatments that are very, very localized, clearly very effective, rapidly effective. I thank you very much for this presentation. And I appreciate your discussion at the end, really highlighting the need for incorporating this in residency education. In that paper that you pointed out, we were essentially advocating a fellowship for interventional psychiatry. I'm not sure if that's ever going to happen, but it's something that I think is needed for the field. So again, I appreciate your presentation. I thought it was wonderful. Thank you very much for a very well prepared and well presented talk.
Thank you, sir. And you know, we actually, sorry, Dr. Lemon, I was going to comment on Dr. Malik's statements here, but you know, and I actually think that we do have a very good opportunity in our department to get that education, especially through some of our elective work in our fourth year. You know, I've been able to do, and I know that some other fourth years have been able to do over 50 ECTs this year, and Dr. Kalal has been quite excellent and quite busy with ECTs. And then Dr. Schroedt's TMS practice is also quite robust, and I've been able to, you know, and I know the residents have been able to get certified in the use of TMS in at least one machine. And so we do provide those opportunities for the residents here. And if anyone has questions about that, please talk to me after the fact, send me a text or an email, and I'll be happy to guide you to how you can kind of you know, get that experience while here at U of L.
You know, one thing it does point out to me, as much as you just said and what Riff said, we are not on the cutting edge here in Louisville. I mean, our machine is sitting idle, our TMS machine. And anyway, we probably need to do a lot better on that. I remember when I came here to Louisville, we weren't doing ECT at times. And anyway, we do need to do better. The other thing that you reminded me about when you talked about that seizure and ECT and stuff like that, there's another area that's very interesting in psychiatry that I've actually been involved in here lately is something called forced normalization. And when your serious epilepsy patients get better, they become psychotic. And when they have more seizures, they're not psychotic, but the seizure is out of control. And there's an interesting balance. And the patient that I'm involved with right now lives in the Netherlands, and we finally had to decide it's okay for her to have an occasional seizure, just not to be quite so crazy. And now we're trying some olanzapine and some other things to kind of get the seizures pretty much under control and the psychosis pretty much. But it's an interesting phenomenon.
So that person was giving themselves ECT by having these seizures and treating it. They stopped getting the benefit.
Exactly. The ECT treats the psychosis. Oh, and that reminds me of another point. There used to be a doc here called Dr. Gultikin, who was the chief out at the Central State, and he remembered giving ECT back in the 50s or something like that. And that he thought we really missed the boat by using ECT as a last resort kind of, and he remembers using it as a first resort before there was any chlorpromazine, before there was any amitriptyline, all that stuff. And he said he thought that sometimes the results were better if you gave it on first break psychosis, first incidence of psychosis.
And I would like to echo the last resort versus first resort statements here with TMS and also with the botulinum toxin. Is, you know, my personal opinion is that they should probably be first line treatments for depression, given the fact that they are targeting an abnormality that we can see on neuroimaging, number one. Number two, their lack of systemic side effects of these therapies. And you know, number three, you know, the access that we have to these therapies. I think that the TMS and toxin, maybe not the toxin right now, but you know, but in the future, the toxin should probably be first line therapies. That's you know, personal belief of mine.
I'm just going to hold on to my head like this.
So Ollie, it sounds like this was essentially found incidentally, but we have postulated a good theoretical basis of why it might work because of the feedback between our body and our brain. Are there studies looking at botulism used for other conditions and its mood effects? For instance, the spastic torticollis, or it's used in the GI tract or other conditions?
Yeah, so there were, and there were a couple of the studies that I didn't present that for their control group actually used folks that got the toxin in other areas. And it showed that the glabellar region was actually more highly linked with the mood effects compared to other regions of the face and neck. The neck, not so much. So the next, so toxin injections to the neck, the only time that was really looked at is with the post-marketing surveillance study that I showed with the FDA reported adverse events. But the migraines studies also show an improvement in mood and anxiety. The theory that they're suggesting is that it's due to trigeminal nerve stimulation, obviously, you know, denervation of the facial muscles impacting the trigeminal nerve. And so my assumption is that it would not work as well with other areas of injection. And fortunately for that theory, or unfortunately for us, you know, the cosmetic literature is what found this first. And the cosmetic literature kind of took spearheaded looking at the depression symptoms as well. And so cosmetic toxin injections are usually done in the face, and they're usually done in areas that are innervated by the trigeminal nerve. But the glabellar injections are more directly associated with the mood effects than the other injections are.
When I was in my training, I spent several months at a migraine specialty clinic, and we did Botox, mostly for migraine, but also occasionally for depression. And I have never seen any research on this or any literature on it, but the neurologist had also given it for people who had spastic muscles of the face and other parts of the face. And he had said that there are some muscles that are associated with smiling, that if you use Botox on them, that he's been able to elicit a depression that was not, of course, his intent, but that was the effect. Not randomized controlled trial, but I thought that was very interesting.
That's very interesting, but yeah, I did not come across that in my research, but that'd be pretty fascinating to look at.
I do want to mention one of the patients we are treating right now has fibromyalgia. And so we're doing injections in her neck and her trapezius. And while, you know, but we're also doing the facial injections. So she certainly gets better and feels better with some of the injections in the neck, in the shoulders, but that addresses directly another disorder that she has, which is very common in folks that are depressed. And I think, you know, there's a few case things about fibromyalgia, but it really I think fibromyalgia should be treated with Botox injections.
And what's interesting too is that there's actually is an off-label protocol for the treatment of fibromyalgia using TMS. And so at Integrative Psychiatry, we actually do have patients with pain and fibromyalgia-related conditions, even some lethargy related to fibromyalgia that we've treated with TMS to good results. I didn't talk about a lot of the off-label stuff in my presentation in the interest of time, but there's, I think there's a lot of room for growth.
Ali, I have a question for you. It has to do with the role of psychiatry and psychiatrists in the future. This is worthy of a lecture to itself, but historically, psychiatry was a much broader discipline than it is now. And many things that other physicians, including neurologists, treat, which were once thought to be primarily psychiatric or psychological in origin, as physical causes of treatments were discovered, have fallen away from psychiatry. As somatic treatments are beginning to be offered for psychiatric conditions, we're already beginning to see this. That is, people setting up ketamine or TMS practices who are not psychiatrists or don't have any psychiatric background. In some cities, this has become quite a controversy. What are your thoughts about this?
You know, so what's interesting is that I asked the same exact question to Dr. Mary Helen Davis and Dr. Kelly Clark at a GLMS meeting when I first met them. And to kind of echo your point, you know, I noticed that family health centers and family medicine practices and things like that, they had psychologists that were delivering mental health care and not psychiatrists. And I was kind of disheartened at the lack of momentum within some psychiatrists about having, you know, opportunities within addiction with treatment with psychotherapy, and then and now that we're seeing that even in TMS and other areas, that, you know, there are a lot of non-psychiatrists that also have TMS practices that I've kind of talked to, and I'm hoping that, you know, as the research around this and the exposure of this continues to grow, that more psychiatrists will be interested and will kind of take responsibility for treating the patients with some of these techniques. In my opinion, and this is, again, you know, I'm nowhere near as experienced as anyone on this panel, really, any of the attendings here, but you know, I think that exposure has a lot to do with it. You know, I think if people are exposed to certain modalities, then it's not as scary for them to try to do those things. You know, one of the reasons that I'm not really scared of toxin injections is because I did facet blocks and epidural steroid injections for years, and so this is you know, kind of a very simple and easy procedure to do, and you know, and through that, you know, actually Dr. Lamalik and I have now been doing injections, and I've done them at Integrative as well, and so it's I think exposure has a lot to do with it. But I do agree with you that I do find it disheartening for when other specialists who may not be able to treat these patients as well as we do because they do have mental illness, you know, kind of take the responsibility of doing that, and we don't. I don't know if that answered your question or not, but I think that this is I think it's a thing that's going to change in the future. I hope it does.
Thank you. I don't think that there is really a clear-cut answer, but you know, psychiatry has become more narrow in more recent years. Many psychiatrists have stopped doing or stopped offering psychotherapy, and other disciplines have picked up that skill and used it more than we have. I think that if there's a somatic treatment for mental illness, we need to try to keep it within psychiatry. And we've done a little better job with addiction treatment, but even that is, you know, it's clearly multidisciplinary and should stay that way, but psychiatry needs to clearly be a part of these things.
I completely agree with you, and I was just going to comment on that real quick. Sorry, Dr. Vincent, but I was going to finish my thoughts on that too. But I completely agree with you, Dr. Casey, and you know, I think that all that has to do with exposure, not only to the treatments, but also, and this is, you know, an unfortunate side effect of the system of medicine that we're in, but also in terms of, you know, how to start or run a practice and how to be successful in terms of treating patients in the appropriate way and in an effective way, but also being successful in our personal lives as well, which is something that I know that you do with your didactics on the business aspect and the practice aspect of psychiatry. And I think that we need more of that as well.
Okay, so thank you for mentioning our article. Both Dr. Al-Malik and Dr. Lippman and I, and several others worked on that several years ago when interventional radiology was a relatively new term. And you mentioned the need for additional training, or perhaps training that's required, which is complicated because the ACGME has to mandate any additional requirements. And there is a big push now for more addiction training because there's only a 1-month requirement. They want all residents to be trained in Suboxone because they feel that that will be introduced into general psychiatry practices more than it is now. And the need for more neuroscience because we have gotten much more involved in neuroscience than when most of us went through residency training. The use of hallucinogens, that is going to open up, that is a can of worms that is already out of the can. You mentioned Botox and use for Botox. I had a patient who, the DSM-4 would have been called a somatoform disorder or somatization disorder. And she was getting vaginal Botox because of her pelvic pain. And there are studies that, as of course it's off label, but pelvic floor dysfunction and pelvic pain do respond to Botox. However, I think it was more than that. I think there was a psychological impact or even a neuropsych impact of the use of the Botox on this particular person. But I wonder if you might comment too about your training in psychotherapy and the doctor-patient relationship, the importance of the doctor-patient relationship when utilizing these interventions that are going to be more prevalent. I mean, Dr. Al-Malik is a great example. He's an expert in psychopharm, and he can talk to patients about everything about their medications. But I think the reason they come back to him is because he's a great doctor. He's a great communicator. He's got the skill set that most patients want to have. So where do you see the doctor-patient relationship in the use of these interventions? And do you think your training has prepared you for that?
Yeah, I think that's an excellent question. And to, and I had that same thoughts about the psychological versus the neurological impacts of the toxin, and whether we're seeing kind of more of a nebulous mechanism at play, or we're seeing a direct mechanism at play with what they talked about with the trigeminal nerve, the ventromedial prefrontal cortex, et cetera. I've had those exact same thoughts as well, and I don't know the answer. That's why I think research and advancing the field is so fascinating, is because it provides us with those answers, or at least hints towards the capital T truth instead of the lowercase t truth. But in terms of the doctor-patient relationship, I mean, I don't think that there is anything more important than that in all of medicine, not just in psychiatry. My experiences in surgery did nothing but solidify that belief that you really have to not only know what you're talking about, but communicate what you know to the patient, and communicate hope to the patient as well. That there is a solution. And one of the things that I say to a lot of patients when I see them in clinic is, I tell them, like, I'm sure that I can help you. I'm just not sure if I can do it on the first try, just because of the nature of the field is the way that it is, that, we might need to change some medications around. We might need to do one modality or a different modality. If we're doing TMS, we might need to do bilateral treatment or do an off-label protocol, but we can help you. And because we have the tools to help you. And that's, I think, and I've had patients tell me that was important for them to hear. And so I think that there's nothing more important than the physician-patient relationship. And part of the physician-patient relationship, I think, comes from confidence, is young physicians having the confidence to know who they are as physicians, to trust their education, to trust their skills, to trust themselves, and trust themselves to treat patients. And I think that comes from experience, but that also comes from, the right nudging at the right amount of time for resident physicians and younger career physicians to really take the reins and take responsibility for the patients themselves. And I think our department does do that pretty well. We have a nice balance between allowing younger physicians to think for themselves and to think independently and develop the confidence in treating patients without having without essentially just following orders from more experienced psychiatrists. And that has to do with the confidence of experienced psychiatrists to know that they taught the younger physicians well enough that we can do that as well. So it's confidence in both areas, it's the confidence in the teaching abilities and the confidence in the ability to learn. And I think those two things are paramount, but you're absolutely right. I think that's one of the most important things in any field that anyone goes into is the ability to have a good relationship with the patient.
Thank you.
I got two quick comments. You talked about psychologists and other people doing these treatments. I mentioned the other day to you, Dennis Buchholz is a psychologist well known to this department, and he is heading up a major TMS project in this town. And that's just one example. The other about Kathy's point about the doctor-patient, I think the doctor-patient relationship is more important than the type of psychotherapy. And we talked about that in one of these sessions. I think how you talk to the patient, whether you're a surgeon or a psychiatrist, is more important than whether you're doing whatever this kind of therapy. And having been around in psychiatry for 50 years, the greatest psychotherapy has changed several times, which one you're really supposed to do. So we're still wondering if this last group is the correct one. And I think that our department needs to do more of this interventional psychiatry.
But yeah, I remember talking to you about that too. That's pretty fascinating. And I honestly am kind of, I'm glad that there are more people doing interventional psychiatric techniques, but I would like for them to be psychiatrists.
First of all, thank you very much for your talk, not only for the materials, but also you are such a good speaker. I really appreciate it. I have a question about TMS. Is that being used also for bipolar depression or not? One question. Secondly, for TMS, do you do follow-up TMS? How is that being done? And I have a third question. Maybe it is a silly question, but I have a cousin who said that she was traveling in a bus and she had migraine headache, and somebody told her, if you put a brush on your forehead and do this in the beginning of migraine, it would help you. And he said it, and she said it did help. And I am wondering if any of our panelists or yourself has heard about something like that, and or if that may even help depression and anxiety, that because that is also a kind of a stimulation here somewhere. It does something.
Thank you for your questions, and thank you for your kind comments and kind remarks. So to talk about bipolar depression and TMS, there are a number of papers looking at TMS for bipolar depression. Those papers have found some benefit for sure, but the results were still a little equivocal from my understanding of the data. There are other folks in the attendees and the panels who are way more experienced at TMS than and know way more about it than I do. But it is done for bipolar depression. My understanding is that there were not that many manic switches, if any manic switches from what I recall. I think there was only one manic switch from the use of TMS on a bipolar depressed patient in a study of about a couple hundred patients actually, and they had improvement of their depression. It is however not FDA approved, so the treatment of that would be an off-label treatment and off-label use of TMS. In terms of your question about the other forms of stimulation on the migraines, I don't see migraine patients very often in practice, in my residency or outside. But I don't. I can't pretend to know enough about it to be able to make an educated comment on that, on the simulation of it. In terms of the methodologies of the actual toxin with depression, it's more closely linked with denervation than it is with activation. The EMG studies suggest that activation of the muscles of the corrugator and the procerus might actually be pro-depression, depressiogenic rather than antidepressant.
Oh, wow. Okay. Thank you. Thank you very much.
I forgot your second question. I think I've answered the first one and the last one.
It was about the follow-up with TMS for depression.
Yeah. So actually, the insurance actually does approve maintenance TMS for some patients that don't have that much of a response. And so in some of the some of the folks talk about doing TMS or extending the period of TMS or having maintenance TMS, just like maintenance ECT, and that has been shown to be of benefit for patients. Yes. The durability is pretty good. So one of the problems with the Saints protocol is that it's so new that we don't know what the durability of that is, because the treatment is about a week-long treatment. You see some effect after 2 weeks, but really the durability of TMS is pretty good with a 30-day treatment protocol. So we don't know that for the newer protocols that are out, but we do know that if you have that some patients do better with just maintenance TMS, and some folks do better with complete reinitiation of TMS. And I don't think that that's 100% clear in the literature. I think some of the other attendings here might know more about that than I do.
Quick, I'll leave just a quick comment about Dr. Rabbani's comment about the migraines and whether some particular kind of body motion or pressure might be useful. There's an entire group of treatments that are sort of in the general range of alternative medicine or alternative psychiatry, at least one of which has moved more toward the mainstream, that have to do with assuming certain body postures or activities. There was a lecture we had maybe 2 or 3 years ago on havening, which is one of those. EMDR, which probably a lot more people know about, is one. Those are sort of another branch of treatments that may or may not be useful, that have been understudied, and are coming to us from some unexpected sources, and that there has been a lot of skepticism about these treatments, which at times I've shared, and yet they're worth taking a look at, but they're generally coming to us from outside of psychiatry.
So 1 o'clock. So I think we've reached the end of our time. Dr. Caudell, is that all right with you? Or if there's any other comments, questions, I'm happy to address them right now as well.
That sounds very good. Thank you.
Thank you, sir.
Thanks.